and we are going to conduct the advanced endodontics workshop in few days. So I'm here to share a few nuances of the basics of endodontics, as we have to break the ice, because every one of you whoever are participating in the workshop, they are doing a root canal in their own way. So there are certain concepts, certain principles, certain ways of doing the root canal in the right way. So I'm just going to incorporate in my presentation today what is the right way of doing it, or what is the generalized principles of endodontics. So it is very important to be in the same platform when I'll start my workshop on the day of uh, proper advanced workshop. So what is root canal treatment? What root canal treatments are comprising of certain steps, and those steps are initial preparation, which includes rubber dam application, removal of caries, access openings, and out of which what I have seen in many cases, I retreat a lot. We retreat a lot. We all of us retreat a lot. So what I have seen is many a times there is hardly any removal of caries. People take the access directly. So there are certain ways of doing it. You have to remove the caries. That means you have to remove the caries. First thing first. That is the rule of any medicinal treatment you are doing. Then comes the scouting. Scouting is nothing but the negotiation. And for that negotiation, sometimes you require to remove the dentinal triangles which are in the chamber. So that's called as a pre-flare. Then comes the shaping. You have a lot of shaping instruments available in the market, and there are so many instruments coming every new day. So now there is always a confusion which one is the right instrument for my case, or what works best in my hand. So there is a lot of confusion. We will do it. We'll try to clear out those confusions on the day of workshop. But now I'm going to talk about basics of instrumentations. Okay. Then comes the cleaning, which is one of the most important part and one of the most neglected also. Rather than shaping, it is the cleaning that affects the success or failure of the root canal treatment. Cleaning comes in cleaning. It comprises of the irrigation in a right way, and agitation or activation of those irrigating solution. Unless and until you activate the irrigating solution, irrigation is not considered as complete. Then comes the apical finishing. The question arises, when should I say my preparation is over and my tooth is ready to get obturated? So that is what is called as the apical finishing. Now, what there are certain criteria to know about the apical finishing, and those criteria are known as apical gauging and patency. And then comes the obturation. If you follow the principles properly, follow the timeline properly, obturation is just a small area of endodontics. Obturation is just the cherry on the cake. That's it. Now, if you see this pyramid, and if we call this as a endodontic treatment pyramid, what do you think? What is the basic or most important step, or what is the base of this pyramid? Whether it is access opening, cleaning and shaping, or obturation. Many a times people say it is cleaning or instrumentation or maybe obturation that makes the difference, but it's not. Most important thing in the entire treatment is the initial step, that is access opening. Why? Because if you miss a single canal, and if you do great obturation, but you missed one single canal, that single canal will cause the case will become the cause of the failure for that case. So access opening always take the base. So when it is a basic, most important step, I have seen that a lot of times access opening takes only 5 minutes, or we do not spend too much of time on the access opening. We just make the dig the hole in the tooth and try doing our instrumentation, because we are very much fascinated with the instrumentation. Whatever rotates, we like. So the same way, we put the file to the endo handpiece and we just rotate it. We like it because it goes inside, does the work for you, and comes out. You have the GPU which is corresponding to the file, and you just place it, finish the case, and ask the patient bye bye. But these are the regular, uh, what I can say, reasons, regular reasons of failure of endodontics. So coming to the access cavity preparation. Now here I'm going to uh, I'm going to cover only basic things of access cavity preparation, and what are the advanced way of doing the access, or what are the advanced way to look at the case. I'm going to talk on that on the day of workshop. So what is the access cavity preparation, or what are the objectives of it? Objective means why I am doing access preparation at the first place, or why I am giving the shape, particular shape to the particular access. Why the access in the central incisor is triangular, upper central incisor, and why the mandibular molar is having a trapezoidal access. So I am going to find out why. Why should I use this? Why should I use that? You should always be having the answer of why I am doing this. So that is called as those are called as a objective. So what is the objective of access preparation? First objective is to achieve the straight line access to the apical foramen. That means if you have a straight canal, like central incisor, if you have, or canine, you have a straight canal, then it is to have the straight line access right from the orifice till the apical foramen. But how many times does this condition presents? Not many times. Many a times apical foramen remain or uh, is on the lateral side of the uh, root. Okay, so many times you get a curved canal. Lot many times. That's why you are here. You want to treat the curve cases more. That's why you are sitting here. That is the whole objective of your sitting or registering for the advanced workshop. So what is another way of looking at it? It is the second line. Now see, or it's a direct line access. If you see the first point, or it's a direct line access to the initial curvature of the canal. Remember, it's the initial curvature. You have two straight lines joining in the angled way. You have two straight lines joining in the angled way to make the curvature. Now, whichever curvature or whichever straight line is near to your eye and hand is the first straight line or first curvature. That means the curvature or straight line which is near the coronal part. So you just have to take the axis and make sure that your axis is directly going towards the inside the orifice. That is what is called as the initial straight line to the initial curvature. Because this is very important in the curve canal cases, and many a times you get the curve canals right in the uh, lower first molar or maybe upper first molar. Many times that's curve canal is too much curved or S shaped or something like that. But always remember that your axis should have the direct line access to the first curvature. Okay. Second objective is to locate all root canal orifice. And third is to conserve the sound tooth structure. Remember, it is called as a sound tooth structure. It's not carious tooth structure. There is a clear cut demarcation between these two. Many times we have seen that access is made in the carious tooth. We get the orifice, we enter the canal, but we don't remove the caries. So whole residual caries makes the mess, and that is what we have to avoid. So remove whatever caries and conserve whatever good. So what are the instruments? What do you want to make the access? These are the basic instruments: straight line, one round burr, safe end burr, one Gates Glidden drill. This is the earlier instrument, by the way. We don't use it now. We have orifice shaper nowadays, and we have to have a long straight probe or DG16 probe, or maybe instrument. If you see the upper instrument, it is having a small K file like structure at the end. That's called as a micro opener. It is available with either Oricam, or you can get with Dentsply. So Oricam one is little cost effective. That's it. Okay. There is something called as a critical pulp chamber depth. What do you mean by critical pulp chamber depth? It is the distance between the central fossa of any tooth to the roof of the chamber. That means if I have a room, this is the roof of the room and this is the floor. There is, sorry, if this is the tooth, top of the tooth, and this is the roof of your chamber. Chamber is nothing but the room. It has roof, it has floor, and below floor there is a furcation, or below floor there is a perforation. So you have to reach the roof, and critical pulp chamber depth is this distance between the central fossa till the roof of the chamber, and this is generally 7 millimeter. 7 millimeter. So do you know, my question, simple question to you is, do you know what is the length of the burr you are using to making the access? Straight burr you must be using. Some kind of a straight burr you must be using for making the access or creating a access opening. What is the length of it? I'm sure that you have never even uh, noticed it. But now onwards, remember that this is very, very important to know that what is the depth of it. Okay, the depth of this. Now, why this is important? This is specifically important in the cases where you have a calcified canal. You never get the drop as such. What we call as a drop, we never get. So where to stop? You have to stop at the length of 7 mm. And from there onwards, you have to be very cautious. You have to move horizontal, not deeper vertical, only horizontal, to make the shape of the axis of plane. Then you look through it and try to find out the orifices. That is why this is critical. This critical pulp chamber depth is very important to know. So remember that it's that distance is not exactly 7 mm. It is sometimes if the tooth is attenuated, it might be just 5 mm. So the range is 5 to 7 mm. Okay. So you when you penetrate the round burr, you get a drop in the pulp chamber. Okay. Once you get a drop, now you have, now this is one instrument by Style Italiano that's called as misurendo. Now you don't require to have the specific equipment for all these things. You all of you have the Williams probe from periodontics. You have the markings on that. You can use that just to measure it. Now, why this slide is important for this? See now, 4 to 6 mm is green zone. What does this mean? It means we are arriving somewhere from the roof of pulp chamber to the floor. So if we already reach this depth, we should already feel the vacuum sensation or the drop, what we generally call it as. Now second is yellow zone. That means green zone means go ahead. Yellow zone means cautious. What is the yellow zone? Yellow zone means you might already have passed the floor of pulp chamber. So if you arrived at this depth, not yet has the vacuum sensation, we need to confirm our location using the radiograph. Understand? And then 9 to 10 mm is the red zone. Absolutely cross, stop. That means you are already in the furcation or already perforated. So that is why you should be knowing clearly that what is the length of your burr. So if you are using a straight burr, long straight burr, generally if the length is 10 mm, you should be entering only 7 mm. That means two-third of the burr. More than two-third if you are entering in, that means you have to check with the radiograph. Take the radiograph. Don't be shy of taking one more radiograph to check where you are. Otherwise, don't make another canal. That means perforation. Understand? So these are the very small tips which are very, very important to know, because I know that you all are very busy practitioner and you might be having 10 patients at a time, few are sitting outside. I know how the practice is done and practice happens. I know that I'm fortunate enough to work in the little city like place where I don't get that many patients. I have some appointment wise patients, but I know how the practice, how dentist is practiced in the areas, in the district places, in taluka places, and everywhere else. And I'm very proud that you are doing greater job than us. What we are doing is you are managing it very, very, very well. It's meticulous. I'm telling you, you are doing wonderful job. So that's why I know that you are having one patient in your chair, another is waiting outside. There is hardly any time you have to get it. So that's why you just put little small checkpoints in your practice. So that will save a lot of your time. So if you know that there is always a favorite burr you have, if you know the length of that favorite burr, it will be very easy for you to manage those cases. So that is how will improvise. Okay. So now how to do all these things, how to gain the access to the curve canal and everything else. So there are certain guidelines to locate the orifice. Many times this happens that you have located mesobuccal, for example, lower first molar, mandibular first molar. You have located the mesobuccal canal, you are not getting mesolingual canal. And you are trying with the burr going here and there, and you are moving all around the pulp chamber floor to find out the canal. Why this is happening? Because you do not know the location exactly. Even if you have done the 100 root canal opening, sometimes this happens. Sometimes this can happen with anybody, any one of us. Okay, so there are certain guidelines laid by some researchers, and those guidelines works wonders. Okay, so what are those guidelines? So there are certain laws of symmetry and law of color change. So what is the first law? First law is accept the maxillary molar. Remember, this does not apply to the maxillary molars. So except the maxillary molars, canal orifices are equidistant from a line drawn in a mesiodistal dimension through the pulp chamber floor, like this. Now see, we have opened the axis. You got mesobuccal canal, you got distal canal. Now whatever another canal you want to find out, draw a line at the floor, not on the top. Don't take a scale and draw a line, just the imaginary line. Okay. And now where you have got from that line, if you got the mesobuccal till this distance, just go the similar distance on the other side. You'll find that 99.9999% of time mesolingual canal is present. So this is equidistant from that line. Okay, this is the first law. Second law is canal orifice lie on the line perpendicular to the line drawn in the mesiodistal direction across the center of the pulp chamber floor. That means the earlier line which I have drawn, chamber, in the chamber at the floor, the orifice is always at the 90-degree angle. Okay, it is always at a 90-degree. It will never be like this or this, except the maxillary molar. Okay, all other teeth with different canals, be it premolar, upper premolar, 2 canals, be it lower molar, 3 canals, 4 canals, whatever is the case. Okay, there are very few exception that does occur. This will never, I'll never say that there are no exceptions. Nature, it is nature. Nature can make anything. But still, these are the generalized laws. Thousands of teeth are studied, and then these laws are laid forward for you. Third law is law of color change. The pulp chamber floor is always darker in color than the walls, like this. See the wall color? Yellowish or whitish. White is enamel, yellowish dentin of the wall. But see the dentin at the floor. It's absolutely brown. So where does this law comes into play? Many a times you must be getting the cases of old age, or you are getting the cases who are chewing betel nut, or they are having a lot of atreted teeth, or the patient with the long standing caries. Now in such certain kind of cases like those, your pulp chamber is all either very small size, or there is a lot of pulp stones already happening in the pulp chamber. So now how will you make sure, or maybe calcified completely? Now how will you make sure that where to stop? So always remember that whenever there is a color change occurring at the bottom, you have to stop there. So that is what is the importance of color change. So tomorrow morning when you go back to your clinic and check your first patient, always remember that, try to find out the change in the color of the floor. So there is something called as a law of concentricity. The walls of the pulp chamber are always concentric. Walls of the pulp chamber is always concentric to the external surface of the tooth at the level of CE junction. Now see, remember, this is one sentence. I will make it simple for you. When now you're not going to cut the tooth from the CE junction to check where is your orifice. Am I right? So what will you do? When you get a patient, for example, upper molar, okay? try to find out where the roots are going. How will you find out? You see the uh, gums on the root. Take your finger, palpate them, where the roots are going. Now, if you know that roots, your gum is like this, so surely your root is also going like this. Surely the canal is also going like this. So your entry point, you will make sure that it will be like this only. Okay, at the C junction. What does mean by C junction? That means at the neck of the tooth, from where the tooth is entering the gums at that point. So what law says? Law says that whatever the shape of the tooth is on the top, whether it is rhomboidal, it is rectangle, it is triangle, it is straight, whatever the shape of the tooth, oval, whatever. But at the base, neck of the tooth, the orifice is equidistant from all the angles, all the dentinal walls. Orifice in the middle is equidistant. Understand? So, sorry, in the middle. So that is what is called as a concentricity. It is concentrated in the middle. So whenever you see, you have to check this point. Okay. Now you're not going to cut the tooth, by the way. See here, law of concentricity. See, it is at the level of C junction, and you can make sure that all the orifices are almost equidistant from the dentin outer surface. Okay. Now there is another rule of rectangle. Okay, this is my rule. I have made it simple for everyone. What is the rule? And this is a very basic thing. Why I'm showing you all this basic? I know that you must have done more than 500 root canals and thousands of root canals. You have opened thousands of molars also. And I'm telling you very, very basic thing, because I just want to make sure that we all should be at a single platform. Everybody should be knowing everything about the access or any other concept at a same level. Okay. So what is the rule of rectangle? Divide molars. This is specifically for the molars. Okay, upper and lower molars. This is for the lower molar. This rule is for the lower molar. So divide the lower molar. Lower molar is nothing but the rectangle. If you see it, it's nothing but the rectangle. So you have to divide the molar. If this is your molar, you have to divide it in four quadrants. This is buccal side, this is lingual side, this is distal side, and this is mesial side. So buccal and mesial, this will become your mesiobuccal quadrant. Mesial and lingual, this will become your mesiolingual quadrant. This will be your distolingual quadrant, and this will be your distobuccal quadrant. Understood? So the molar, which is rectangular, we are considering molar, which is rectangular, we are dividing it into four parts, and those four parts are named according to the cuspal side or the sides where they belong. Understand? Now, if you see the access opening, your distal canal, you'll find it somewhere in the middle of the tooth, middle of that rectangle, or little on the distal side, not much, too much on the distal side. Do not go below the distobuccal cusp to find out the distal canal. It's the biggest canal. You will find it immediately. So you have to start from where? Central fossa, towards moving your burr towards the distal side and entering. You will get a drop. If at all it's a simple case, you will get a drop. Okay. And that drop means you entered the chamber. If you put your file, your distal canal, you will get immediately. It's a big canal. Where does it lie? It does not lie too much on the distal side. It is somewhere in the middle or little distal to the middle of the access opening or middle of the tooth, you can say. Now, where will you get the mesiobuccal canal? Mesiobuccal canal is right below the mesiobuccal cusp. Okay, it is on the buccal side, right below the mesiobuccal cusp. Where will you find the mesiolingual canal? It will never be below the mesiolingual cusp. It will be somewhere in the middle or little on the lingual side of the middle. Understand? So majority of access lie in the mesiobuccal quadrant. Understand? So most important part of your tooth will be the mesiobuccal quadrant. Okay. Similar rule lies for the upper molar. It's a rhomboidal shape. You must have seen that. You must have done this exercise in your second year of your or maybe first year. If you are new people, it's first year. In our time, dental anatomy is in second year, was in second year. So whatever, we used to do the wax carving. So we used to make in first cut of the wax for the upper molar is making a rhomboidal area. So this is what is a rhomboid. Rhomboid is a basic shape of that molar. Now you divide the rhomboid into again four quadrant: mesiobuccal, distobuccal, mesiopalatal, mesiolingual or mesiopalatal, or distopalatal or distolingual. Okay. Again, your axis, mostly axis lies in the mesiobuccal quadrant. So remember that there is an oblique ridge running from the distobuccal uh, cusp to the mesiolingual cusp or mesiopalatal cusp. Many a times you need not even cross the oblique ridge. Oblique ridge lies like this. This is the distobuccal cusp. This is the mesiolingual cusp, and there is a oblique. The entire axis lie in this part, that is mesiobuccal quadrant maximum. Okay, many a times you need not to cross this oblique ridge. The moment you keep the oblique ridge, the strength of the tooth is preserved. So this is very, very important whenever you do the access. Okay, so this is for the just two example of bigger teeth. Okay, even for the premolars and all are very easy. For you guys it is easy, but if you have certain problems with those access, we'll discuss on the day of the workshop. Okay, so these are few pictures of access. See here. Okay, so this is the access for maxillary molar. So now remember that there is one more canal in the maxillary molar, and it is always present. Why I said always? It always present, but it is not always treatable. Many a times you cannot treat the canal. You can see it, you can feel the orifice, but you cannot enter in. It is so thin many times. But whenever it is possible, you treat it, because I have seen that in my practice of so many years. I have seen that somewhere down the line, you will always get the problem with the mesiobuccal canal if you miss mesiobuccal 2 canal. Okay, and where will you find it? You will find it just lingual to the mesiobuccal 1 and on the little mesial side of it, not on in the line of mesiobuccal and palatal. If you make a line, if you join mesiobuccal 1 and palatal, you'll find MB2 little on the mesial side of that line and on the lingual side. Lingual. So what is the best way to do that? First, you find out three important canals. Are three प्यारे canals, easy canals, जो सबसे अच्छे लगते हैं, जे सगळ्यात जास्त आवडतात. कुठले canals? First three canals: mesiobuccal, distobuccal, and palatal. Okay. After refining these canals, after making the orifice proper, your access, everything, now you try to find out the any blackishness, any darkening, any color change below the dentinal wall. I'm talking about the wall of the chamber, not the floor of the chamber. See that. See, look at this. This is the wall which is hiding your orifice, mesiobuccal 2. Now, if you not open up this dentine, you will never find this. Now, how this will be seen? This will be seen grayish on the top, like this particular case. Okay, just try to explore it. Can you see that? Now, how will you explore it? First and best instrument to explore this particular canal is ultrasonic tip. Simple ultrasonic tip. Every company, if you have woodpecker scaler or setlac or EMS or whatever, they will get the endotip for you, and you just have to move that endotip in that area to remove the little dentin which is on the top of the canal, which is hiding the canal. The moment you remove the dentin, you'll find the way in. And if you see this file, see how it is going. It is actually curving in the wall. It is going in the wall. So this canal is actually goes inside the wall. So basic things to find out the MB2 is first remove this dentin with the ultrasonic और वॉर्न ऑफ बर. आपका जो बहुत ज्यादा यूज हुआ बर है ना, वो यूज करो, और use the burr with the micromotor so that you will cut less dentin. Understand? And open up this. The moment you open up, many times you get the canal orifice. Okay. Second thing is, generally MB1 and MB2 there is a difference of little 0.5 millimeter. So if you get a MB1 here, MB2 you will not get the same level, little down. So dig deeper. But what will you use to dig deeper? Don't use air rotor. Just use the ultrasonic. Even the normal scalar tip will do. Let me tell you, don't invest in anything. Normal scalar tip will do. Okay. So that is how you will find the MB2. See here, prepare it and finish our case. See, this is the case where I'm using ultrasonic tip. This tip is from Dentsply. Tip is Startex number 2. Now see, I already got MB1, distobuccal and palatal. Now I am just exploring that particular area. Okay. And I'll irrigate it. See now, when I have found MB1, DB and palatal, I had prepared them little. So after preparation of this, it is very clear for me to where to go. Understand? See here how my file is going 10 number. It is going in the wall. It's going like this, in the wall, not going straight. Okay, not going straight. It is going like this, in the wall. Okay, just go ahead with the 10 number file, little, whatever length it is getting accepted, and then now you can go ahead with the normal your preparation, whatever you do your preparation with. Okay, you'll get MB1 and MB2 and all. You just have to find out. Okay, try to find it out. Okay, this is good exercise for you before you come for the um, workshop. So if you are not till getting MB2, I have given you enough tips how to get it. Now coming to the access cavity, there are three different types of access cavities. First is called the traditional, then is conservative, and then there are small cavities called the ninja, truce access, or mouse hole access. Now these three access are actually irrelevant for me. I'm practicing from so many years. If you ask any person in the world who is doing a good endo, he will never advise you to just go for the miniature accesses. Okay. So what are the different accesses? See the traditional access. In traditional access, we actually remove the entire pulp chamber. What was the motto that time when traditional? In a mirror, you should be able to see all three canals. Now that's not the case. You have to tilt the mirror to see distal and see the mesoderm. The moment you see everything in the middle or everything in a same view, that means you have cut more. Understand? You have opened it like this. You are not supposed to open it like this, like inlay. You have to be little conservative. Okay, wherever you can save the dentin, you save it. So if you have a chamber like this, if you have a chamber, just open the access like this. Okay, open the access like this. So you have saved this dentin on the top and you have saved this dentin on the top. Okay, so that is how it is. But if you make a very small axis like this and I have a canal hidden here, I cannot find it. So in ninja axis, what happens? You make a very small hole, and through that small hole, by using microscope, you try to find out different orifices. मला सांगा तुमच्याकडे किती वेळा असे केसेस येतात की ज्याच्यामध्ये दात असा असतो जसा त्या स्लाइडमध्ये दाखवला आहे. देयर इज नो केरीज, नथिंग. दॅट्स अ आयडियल टूथ कट इन द सेक्शन. And now you're showing the all kind of access openings. Now we get generally patient with the class 2, big class 2 going inside the pulp chamber, destroyed tooth, subgingival caries and all. How will you stick to that ninja access? So it is highly, highly difficult to get all those requirements made for that ninja access. Now there comes the conservative access. What is the conservative access? Conservative access simply means that whenever possible and wherever possible, try to save the dentin as much as possible. Why? If you save the dentin, the strength of the tooth will be saved. Okay, so that is what conservative access is all about. So how will you do it? For example, you have the caries from the mesial side of the mandibular first molar, and now you know that the entire axis lies in the mesiobuccal quadrant. And you have mesial caries. So you just remove the caries and try to find out the way to enter in from that carious part only. I mean carious side only. Remove the caries first. Remove the caries first. Make it very clear. You must be entering the canal. The moment you enter the canal, try to remove as less as possible. So maybe you are hardly doing any preparation, okay, and you are inside. So that's what is called as a conservative access. So conservative access might be from the side, but it will be fulfilling the purpose. You will not be missing any canal. You will be getting all the shapes of cavity whatever you want. Okay, now see this case. This is one of my friend who had come for the root canal for me. The specific case, very special case. This is the upper first molar with the two palatal roots. If you see that, there are two palatal roots. Okay, four canals. And see here, I had finished it. Now, if you see the obturated IOPA, especially negative of that particular IOPA, see the portion of filling which I have done, post RC filling. Okay. Now see the dentin on the distal side is completely saved. I have gone through I have accessed that tooth from the filled portion or carious portion of the tooth only. That means from the mesial side. See here, clinical pictures. See, I have removed the caries. Top left hand first, top left hand first picture. I have removed the caries. Can you see the small perforation in the chamber? So here I have given, for example, you want to give the intrapulpal, this is the right time. Now see the oblique ridge was also there. See the second picture now. I have opened up completely, removing the caries and everything else. My oblique ridge is still intact. Absolutely. I need not to open up anymore. Then irrigation and everything else, you can see all the orifices in the irrigation. That irrigation, that liquid I had put it just for the sake of photograph. Okay. And then obturation. In the obturation also, I can see one canal in the mirror at a time. Another canal, I have to tilt the mirror. That is how. And then there is a post-root canal. The similar case which I have shown you just now, the X-rays, these are the clinical picture. So now see how small the access cavity was. So now this case from last 5 to 6 years is without crown and still surviving. As she is dentist staying in Dubai, I had 100 times told her that you make a crown, and 100 times she denied. She said, "Ha, kar dungi, ha, bana dungi," and that is how it has just. When I have say, I had a good follow up of this case as well. Okay, so you can go for the conservative access whenever possible. So if you are opening up too much, now onwards you try to open up little more, but little less. But after removing the caries, do not keep the caries there. That's the first step. See the another case. Can you see that? Can you see that there is a small opening in the pulp chamber? There is little pulp exposure. Just go through that part only inside. See here. Can you see that? Very small cavity, lower molar. Very small cavity. You can enter in easily. See here. Can you see that? I can enter in from that area only. But remember that whenever you entering in, you should not miss any anatomical feature, like any orifice you should not be missing any canal. But for such kind of a cases, you have to have at least little magnification, at least the loops. Then you can achieve such kind of accesses. That will be better for you. I am not saying that you have to use the loops, but I still insist you to buy the loops, and it should your next buy. I'm telling you, the moment you enter in the field of magnification, the dentistry will be newborn for you. It will be altogether different experience of dentistry if you use the loops or any magnification tools. Okay, so try it once if you have any chance. See here. Now the dentin on the top of the distal canal. Can you see that distal root? There is a dentin on the top of it like this. The canal is here somewhere. Now this portion is called as a soffit. Soffit. This portion is soffit. What do you mean by soffit? Soffit means sajja. Sajja, every home, earlier home, were having a small sajja. And on the top of the sajja, people used to keep all utensils and everything else. Why that sajja is made in the older homes? There were no concept of pillars and everything else. Plinth was not there. All the houses are right from the ground. There was no pillaring inside, though no reinforcement. To avoid the fracture or to avoid the destruction of the house under any stress, they used to give a sajja, and that is called as a soffit. And this is what we are trying to get in the conservative axis preparation. So a little more soffit will also add a lot of things to the strength. So fracture resistance will increase. Okay. So stress to success. I think this much is enough, but this one point I would like to tell you. Trace to success, what does this mean? I have asked you to make a X-ray, IOPA, and make an enlarged image of it. And this particular exercise is for that. Okay. This tracing, you have to trace the anatomy of your tooth. There is a case like this. Now you have a case like this. You know that this is a difficult case for even for any endodontist in the world. Okay. This is not a simple case. There are so many sharp curvatures inside. I don't know which file is going to stay there only. Any file can break at any point of time. So what I am supposed to do is I have to prepare myself and I have to plan this case beforehand. So for planning, you have to have a tracing. You have to have the X-ray in your hand. Keep it in front of you. Mark properly where are my roots, where are my canals, how the canals are going, which file I'm going to use in which part. For example, this was my plan. Which file, which coronal shape, orifice shaper I'm going to use. In middle third, how I will go. See here, middle third, path file I will use. Then I will use 17 4% file. Then I'll enter in with the 24% file. After I'm using 24% file, I will think about the apical one third. How will I go ahead with the apical one third? Again, I will use the glide path file. Then 15 3% file. There are certain number of files which are in between, 12 number file or something. That means I would like to tell you that you should have the plan for all these things. Now, when you know that this kind of a difficult case is in front of you, you should have all new instruments lined up in your tray. Your associate should be knowing that this is the most important case and you should be able to devote the time for that case. Unless and until you do that for your first case, you will not learn anything new. You have to unlearn certain things. You have to leave certain things behind to learn something new. You want to have the better experience. If you want to have a different experience, you have to lose something which you are doing from years together. So this is what you have to do. This is small exercise which you have to do on the day of workshop. So that's why I require you to have good molar with a good access, good anatomy, and you have to have one IOP of that. So that is what is the plan. And then once you stick to the plan, you'll get the success. Can you see that? So what do you have to do? You have to trace, you have to plan, and then you have to follow the plan. So follow the plan. That is the concept. Okay. So you can identify all the orifices like this. Can you see that? In the mandibular molar, specifically in the Indian patients, I have seen that. I mean, I don't have any evidence now. I have not studied for that, but I have seen that. What I have seen that I'm just sharing with you. There is a canal between the mesiobuccal and mesiolingual. That canal is called as a middle mesial canal, but it is hidden under the lip. There are two canals, mesiobuccal and mesiolingual, and there is one canal like me in the middle. But on the top of me, there is a dentine like this. You have to remove that dentine. And how will you remove it between? You have to remove that dentine with the vibration of ultrasonic. Okay, so that's why ultrasonic is very very important thing which you should introduce in your practice. That will reduce a lot of your time in the treatment. That will increase the success rate, predictability of your treatment. Okay, with the ultrasonic, I just remove that lip in between mesiobuccal and mesiolingual canal, and I'll open up the isthmus between these two. And now to stress the isthmus with the DG16. Do you have the pulp tissue in that? If you have pulp tissue, just move your DG16 bar like this and remove the pulp tissue. Take your 10 number bar, 10 number file, K file, and enter in with the 10 number file. You will find that if the canal is there, you will get it. If canal is not there, your isthmus will be cleaned by the DG16 on 10 number file. That is very important. Okay. So try to find out. Try, but don't make a canal. Don't make a canal. Don't perforate. Just try to find out. If it is there, you will get it. Okay. But like this kind of cases like this. Okay. A lot of cases you get. Don't worry. Okay, so that is what I would like to stop here with the access opening. Hope you will like this video.